Clinical features. So many of the tumors will not produce any symptom, and sometimes the tumor will be discovered during a routine physical examination as a palpable abdominal mass. So in 10% of cases, the patient will be having classic triad. So the classic triad involves hematuria, pain which is there in the flank region or near the hip, and the third symptom is abdominal mass. Mass may be over the abdomen as well as lower back. So this is classic triad. Other symptoms like weight loss, fever, hypertension, and anemia can be seen. And most significantly, the patient will be having paraneoplastic syndrome. So we have already seen that the paraneoplastic syndrome means the tumor cells can produce hormones, which is actually produced from other parts of the body. Sometimes tumors can produce some hormones which can activate other hormones. So that is paraneoplastic syndrome. So here in kidney cancer, renal cancer, we can see production of erythropoietin by the tumor cells. So what will happen? The increased level of erythropoietin in the body will lead to increased RBC production, and it will lead to polycythemia. And next, these tumor cells can stimulate as well as produce renin. So renin-angiotensin mechanism will stimulate, leads to hypertension. Sometimes renal cells, the cancer cells in the renal system can produce parathyroid hormone related peptide, PTHRP. So as a result of that, it can lead to hypercalcemia. And this parathyroid hormone related peptide can stimulate another hormone, adrenocorticotropic hormone. Again, it will lead to cortisol formation and leads to Cushing syndrome. So in renal cancer, the patient can also experience polycythemia, hypertension, hypercalcemia, Cushing syndrome. It is not seen in all the patients. Individual differences will be there. In case of large renal cell carcinoma, that can compress the venous drainage mainly from the testis. It will lead to dilation of the testicular vein, which can ultimately lead to varicocele. So local extension of kidney cancer into renal vein as well as vena cava is common. It can metastasis into lung, liver as well as long bones. So these all are the clinical features. Stages. Coming to the stages, there are mainly 4 stages. First stage is the tumor can be up to 7 centimeter. Here you can see the color. So here tumor can be up to 7 centimeter and limited to kidney. Second stage is tumor will be more than 7 centimeter, but it will be limited to kidney. Stage 3, tumor will be there in major veins as well as in adrenal gland, but within the fascia. And stage 4, tumor will go beyond the fascia and it can affect more than one regional lymph node which is involved. So these are the stages. TNM classification, you can read the TNM classification. Read this TNM classification and stage accordingly. So stage also you have to read. So in WhatsApp group I will be asking what you mean by stage 1. So you have to tell T1, N0, M0. What do you mean by stage 3? You have to tell any of these, T1, N1, M0. For example, we can see what is stage 3, T2, N1, M0. T2 means tumor more than 7 centimeter, which is limited to kidney. N1, metastasis in single lymph node. N0 means no metastasis. Similarly, you have to relate and study. Diagnostic evaluation, history and physical examination can be done. We can palpate the mass. We can ask about the causes, related causes. Physical examination, we can find out obesity, hypertension and all, or related causes. Urine analysis, ultrasound, CT scan, MRI, renal biopsy, renal scan, angiography. Renal angiography also can be done. Coming to the management, most commonly done treatment is surgical management. Partial nephrectomy can be done or radical nephrectomy can be done. Otherwise, ablation, cryoablation as well as radiofrequency ablation. Radiation therapy, chemotherapy, biological therapy, targeted therapy rarely done, mainly during the metastasis or done as a neoadjuvant therapy. So surgical treatment is most commonly done, partial nephrectomy as well as radical nephrectomy. So here partial nephrectomy is done when there is bilateral kidney involvement. That means both of the kidney is having cancer. We will do partial nephrectomy or nephron sparing surgery. Why? Because we can't remove both kidney together. Kidney is needed for the patient to survive. Otherwise, the patient has to go continuous renal dialysis. Continuous dialysis the patient has to undergo. That is not possible. So here we can go with partial nephrectomy. Otherwise, we can go, if unilaterally the patient is having renal cancer, we can do radical nephrectomy. So the treatment of choice for some renal cancer is partial nephrectomy or radical nephrectomy. Radical nephrectomy involves removal of the kidney along with adrenal gland, along with the surrounding fascia, as well as the ureter or draining lymph nodes. All these things will be taken out. So nephrectomy can be done in two ways, open method or conventional, or laparoscopically. Nowadays, laparoscopic surgery is commonly used. So when we are using open approach, an incision about 6 to 10 inch should be made. That is, several layers of muscles should be cut. So incision can be over the flank or abdominal area. Very difficult. Laparoscopic nephrectomy is commonly done nowadays. It needs 5 punctures, and we are using the laparoscope with a miniature camera so that the surgeon can visualize with the help of video monitor. So once dissected, the kidney is maneuvered or moved very carefully into a nylon impermeable sac and then safely removed from the patient. So combined with conventional or open nephrectomy, laparoscopic approach is very painful. It's less painful and it involves shorter hospital stay as well as the healing will be very fast. So commonly this is being preferred. So preoperative management that we will see in next video.